Hello, and welcome to another episode of Your Public Health Professional and You, a program of the Maryland Public Health Association. I am Lillian Agbeyegbe, your friendly community health educator and host for this program. On Your Public Health Professional and You, we engage members of the public health profession. We learn about what they're doing, how it benefits you, members of the public, how they get to the path of public health, and hey, if we can interest you to consider public health as a profession, we throw that in as well. Today, I am talking to another phenomenal public health practitioner, and yes, all my public health practitioners are phenomenal. I'm talking to Dr. Marissa Robinson today. Dr. Marissa Robinson, thank you so much for joining me.
Thank you, Dr. Agbeyegbe, and it's so nice to be with you, and hello to all the viewers out there.
Awesome. Great. So let's start by getting to know a little bit about you. The one thing we know so far is that you're a public health professional, but tell us a little bit, who is Dr. Marissa Robinson?
I'm so excited to be here and talk a little bit about my public health journey. I think for so many people, you stumble into public health, you go an alternative path from science and medicine to loving public health. And I was one of those individuals that always thought I was going to go to med school and that was the end all be all. But in my senior year of high school, I had an internship at NIH, and I worked at the Institute of Human Virology at the University of Maryland, Baltimore. And there I was learning about something, as we all know, as HIV. And within the study, we were looking at persons that lived with stage 3 HIV, and if they had lower stress levels, they were living longer. And within that data set, I started to realize that a lot of the individuals that we were talking about, because I was a research assistant, all of the individuals within the study were African American or Black. And so for me, coming from Maryland, I was like, whoa, what is HIV? How can I do more? Because this is disproportionately impacting individuals that look like me. So that really catapulted me into like, okay, I'm going to be a chemistry major. I'm going to be a physician. That's it. And then I learned very early on, I went to Spelman for undergrad, and I learned very early that that was just not my ministry. And that's okay. And so from there, I pivoted from chemistry to psychology. And within the psychology background, I learned that you could do a minor. And so at the time, public health and environmental health was a dual track at Spelman. So I actually double minored in environmental health because I was really big on like recycling, planting trees, and just really being an environmentalist. But then I learned about public health and like, what in the world is public health? Oh my gosh, instead of just having patients and small cohorts of individuals that are making impacts of change and promoting health and well-being, I can create change within populations. Sign me up. And so from that point on, I was doing research, I was in the community, and I really started to understand that public health was really more than just the individual perception, but the population perception. And so after that, I went into the Peace Corps, and I served in Togo, West Africa as a community health and malaria prevention volunteer. And from that point, I knew that global health was definitely something that I wanted to learn more about and figure out how I can do greater impacts beyond the borders of just where I was living at the time. And so from there, that really started my federal career. And currently I serve as a health equity specialist lead in the Office of Infectious Disease and HIV/AIDS policy.
Awesome. I'm like standing and clapping, but I don't want to overdo it. People will like, of course she's a public health practitioner. You will be excited. But no, really, this is phenomenal work that you're doing. And two things that I wanted to circle back on to now. You're working on health equity. When you looked at data, you're saying that this was something that was disproportionately affecting African Americans. How does being a public health practitioner allow us to be able to identify those differences? Because, somebody's working on the street and doesn't really know, or maybe those people are presenting for healthcare services and they're receiving healthcare services. It doesn't really tell us who's disproportionately affected with what. So how do you think that public health provides that opportunity for us to be able to identify those things and to do something about it?
Yes, so in a lot of what we do in public health is figuring out how do we interpret data to the common individual who doesn't have all these degrees behind their name, right? And it is truly a gift, and it's something that we learn over time. You don't just wake up and say, all right, I can effectively communicate and I will be able to break down really complex data and systematic issues. So over the course of my career, I've made it very imperative to not only my own training, but also my colleagues and folks that I have been in communication with, of learning how to effectively be able to transcribe and describe what is going on in the public health infrastructure. And for something as easy as epidemiology, for those who are epidemiologists and who are really nerdy and love the statistics, and for our biostats folks, they love the data. But sometimes when we're communicating to the public, the data is where they get completely lost. So we have to have the reminder that data points are people and our people's lived experiences. So when you bring that qualitative data part into the discussion, to bring those anecdotal stories, those individuals who are impacted disproportionately from maybe a health outcome or something like infectious diseases, you can really bring the data alive to somebody that would have never known about that person's lived experience if we only talked about statistics. And so I always love to humanize what I am talking about and really to be able to connect to the viewers that I'm speaking to. We always have to know who our audience is, and that is first and foremost. So sometimes you might be speaking to academics, so you can use a lot of jargon. For our fellow USG partners, we can use a lot of jargon. But when we're talking to community, we want to describe what are those acronyms that we're using. If there is any sort of definitions that we can provide ahead of time, we want to define those things very early on in the discussion so we don't lose people. And then again, humanizing and centering person-first language and keeping things at a very low reading level so that everybody is a part of the conversation and feels included, because that is a part of inclusion and belonging.
Awesome. And when you were talking about, so we don't lose people with acronyms, I remember I was going to point out when you said you went to the NIH. For people who don't know, that's the National Institute of Health.
Yes.
Yes, absolutely. And so many things to unpack there. But what you're saying really is the diversity that exists in public health. And you talked about the epidemiologist, and you're talking about, the biostatistician and doing the work. But then there's also the health educator and the community advocate, because our work really isn't just interpreting the data. You're working in HIV/AIDS in policy. So when you're talking about policy, you're talking about talking to elected officials, I imagine, or big or small policy, and getting those things changed. Can you talk a little bit about the diversity of the public health profession and how it affords people to come in at different points?
Absolutely. So within the public health space, we have individuals that are community health workers, peer navigators. You might also have research assistants, public health advisors, all the way up to our clinicians. So those that have degrees of medicine, dentistry, our nurse practitioners, our folks that are in like phlebotomy services, and those that actually provide direct care to individuals. Then we have a whole slew of people who are in between, right? So you have your front desk people that are in public health organizations. We have our community-based organizations. We have nonprofit sectors. We have our public-private partnerships. So we have private companies like pharmaceutical industry, for example, consulting firms. There are so many people that touch the world of public health. And then that's not to mention our academic institutions. There are so many individuals that are doing research and that are training the public health professionals that are coming up into academic institutions. And then we also have our persons of lived experience and those that are experts in their own lived experiences. So I also want to center those individuals, because it's not always about who you know or about the degrees that you hold or the training that you've had, but what experiences have you had that make you an expert in the field of public health?
That is a very diverse group, a wide, spectrum of people. from the clinicians to the front desk person. And
Yes.
so all of these people you're talking about, I would like to think that they didn't all just get into the profession yesterday. But
Right.
as you know, there was a lot of pushback on public health during the COVID pandemic. How do you explain that we have this field that has so many people working in various sectors of the field, and then we have a pandemic and there's this disconnect, or there was this disconnect between the profession and the public that it caters to, as it were?
Mm-hmm. So a lot of the individuals in my profession, which is infectious disease work, were called on. We had to drop everything and jump right into COVID-19 response. And at one point, we were in an emergency use authorization time period. So we were truly in an emergency response. So we were really reactive, and we had to drop whatever we were doing to really focus on how do we help the public stay the most safe. And that really was on the infrastructure of our public health workforce. And many of our workforce were burnt out. Many of our workforce got sick. Many of our workforce were really relied upon as the first responders to a lot of the rural communities, to our indigenous communities, and to those that are in lower socioeconomic areas. And so to think that those same individuals are trained professionals that are trained in science, medicine, as well as public health, it was really alarming to see some of the reactions that we had throughout the COVID-19 pandemic. But I will say some of the positive things that came out of COVID-19 were certainly telehealth and telemedicine. We have been trying for decades to update the public health infrastructure to be able to provide services in a virtual capacity. We've had Skype and Zoom, and we've had FaceTime and all of these video messaging tools for social and public consumption, but we never updated it for the public health workforce. And so seeing that advancement was really phenomenal because it moved us forward to be able to address the needs of those who were immobile, for those who didn't have access to transportation to get to their appointments. And there were also, a lot of barriers that we identified. And so with those identification of barriers, we were able to address some of those really significant changes in our public health infrastructure. But that is just a little small snippet of some of the positive things that came out of really relying on the innovation of the public health workforce. And then when you talk about vaccines and just how much science has really moved forward and how fast the production was and how fast the uptake was, there were a lot of challenges. And I think we acknowledge that as public health workforce, but how do we address those challenges and move forward so that in the next pandemic, because there will be, more things to come, we have to think more proactively instead of reactively. And some of the systems that we put in place between COVID-19 and now, we have really helped to bolster our public health infrastructure, and there's more to come.
Thank you so very much for that. I think one of the things I really liked that you talk about was really the telehealth bit, because now I'm calling my primary care physician, and they were offering options of, do you want to come in person? And like you said, it was something that public health had, somewhere where public health had already been to, but we haven't been there as a society, and we're now finally able to get everybody to go there. So talking about where public health gets to before we get everybody along. You are a public health professional and you're there, and you know that the work that you're doing benefits members of the public. But somebody say, I don't know you. I'll never get to see you, Dr. Robinson. How can you say that the work that you're doing is benefiting me, even though I will never get to meet you? What do you say to somebody who's saying, how does your work benefit me? Our paths will not cross, but you're saying you work for my own good.
So that's a great question. And I feel as though many public health professionals face that same question, because it's like, when you get to Thanksgiving dinner, for example, people are like, okay, so you're a doctor, but you're not a physician. So what do you do again? And like, what does that mean? And how does that impact the public? And so for many individuals, you will never see the work that I do because you are not one of the individuals who is living with the infectious diseases in which we focus on in specifically my office. But for some of those who I've spoken to throughout platforms such as podcasts and other things, I talk about the work that we have done for ending the HIV epidemic initiative, as well as some of the prevention tools that we have out in the public. And then we also have a website that a lot of individuals go to learn more information, specifically about awareness days, about community activities, and about different things that they can do to get more involved in the prevention or for individuals living with HIV, the care and treatment of that. And now that I'm in the health equity space, we're all about making things more accessible and making sure that no one is excluded and making sure we're trying to achieve equity for all, no matter what the disparity is. And for the average individual, you might not know it or realize it, but there is probably a disparity that you are living with that has just become part of your daily natural life. And if a public health practitioner were to pick apart, what you are going through on a daily basis, they could identify at least one thing that you are living with that you have either overcome, you've just decided to address it or just move on, or there might be something that could be completely unknown that you will not know until you go to a healthcare provider or until you go to a health conference or until you listen to this podcast, for example. There are so many opportunities to learn more, and public health is not just one thing, right? And I think a lot of times the public wants to label something. We love to do that in the academic space. We love to give things labels and titles, but sometimes when you think about the whole picture of public health, it can literally be any and everything all at the same time. And so I think that that's really important when we're talking about workforce, when we're talking about who is impacted and how they're impacted, but ultimately myself, yourself, and everybody in the public health field, for the most part, is doing their job to protect the lives and promote health and well-being to the individuals in which they serve. And even though they might not identify you specifically and tie you to a specific role, there are so many people that are working to make sure that the general public has the resources, gets the access that they need, or are connected to services. And we were just talking before we started the recording about a recent documentary that came out entitled The Invisible Shield that's available on PBS. And I think that that's really where the public is. We have been so protected by public health for generations, and we really didn't realize it until something like COVID-19 pandemic happened. And you realize all the different layers of public health that touch you each and every day. So I think that that's a real summary of how maybe myself, yourself, and others in the public health field are impacting people's daily lives.
Absolutely. One of the things I like about the Invisible Shield is that it's available on PBS, because something that used to grieve my heart was really that documentary, Is Inequality Making Us Sick? And how it can only be accessed, in academic settings, because I'm like, no, people need to see it. And I try to order it, for myself, but they're like, it has to be ordered by an institution. I'm like, but this is information, because inequality was making us sick. And that was a brilliant documentary. So I'm really glad that we have this on PBS now. But in terms of even talking about the work, when people ask me, so I worked in the field of HIV/AIDS here, but I also worked in the field of HIV/AIDS in Nigeria before I came to the US. And I was working in oil rig stations. So Chevron, the oil rigs, they have stations where they have workers coming from all over the world, and they are on the oil rig for a period of time and they go off. So you have people come from different parts of the world and different parts of the state and come to this one state. Well, in this one state also, they have university campuses, which also has students who come over from different parts of the country to this one campus. And so this oil worker comes, has a, unprotected sex with this student who's on this campus, who has a boyfriend on campus, which is this worker, goes back to their community, has a boyfriend at home, and has unprotected. So we see when we're talking about transmission by sex, and we're talking about these people who can go into different places. So somebody can be thinking, I'm not coming in contact with you, but you may come in contact with somebody who's safe because we have educated them about, being safe in the way they engage in their sexual activities. And that person is now not in a position to infect you because they've taken all the necessary measures that they've benefited from the public health practice. So you have benefited from public health, even though I didn't come and say the message directly to you, but you have a partner who could have been exposed, who was at risk, but who didn't get infected because of information they received from some public health practitioner. That's one of the way I think about how we're really impacting people that we may not come in contact with.
Right, right. And even something like this recording, even though we're meeting virtually and we're recording this, the same thing can be said about public health messaging and some of the conversations that happen during podcasts, during conferences and webinars and things like that, that these recordings are put onto websites, right? And then the website might have traffic of individuals, and you might get a repost or somebody who comes across the video and finds a nugget of information and shares it with one friend. And then that friend shares it with another friend. And so your original reach of only a few people who might come to your website or, your conference or your seminar or whatever it is, it can reach a much larger audience. And I do think that just like telehealth and telemedicine, being able to have these conversations across different state lines and global lines is really important because unfortunately, infectious diseases doesn't have any favorites. They will cross borders, orientations, genders, races, ethnic backgrounds, it doesn't matter. And so that is one of the tools that we know. And so if that is in fact the case, what are we going to do about it? Let's educate, let's spread awareness, and let's continue to spread the message about how do we address the needs of individuals potentially living with HIV. And then for those that may acquire HIV as well, what can we do for them to get them into treatment and into care and achieving something called viral suppression so that the amounts of HIV that they are living with are something called undetectable equals untransmittable, or U equals U, which in turn basically means that they can no longer acquire HIV to another person cannot acquire HIV from that individual if they are on medication and virally suppressed. And so changing the narrative from, okay, at risk to what have you done to protect your health and the health of others in a way that you feel that you are in control of. And so I always bring it back to the individual and they can make an informed decision based on how they want to live their lives. But there are so many tools in our toolboxes, whether it's prevention, care, or treatment. And so I always bring it back to those kind of pillars.
Prevention, care, or treatment. Awesome. Great conversation I'm having with Dr. Marissa Robinson. Let's talk to those people out there who are like, okay, so now you've got me a little bit interested. Is this something I can consider? Because we know that we have an issue of workforce shortage in terms of public health. So if for somebody who's sitting on the fence, or somebody who's even maybe already doing something and they're thinking, how do I transition into public health? Is it worth it? Or somebody who just wants to go into college and is like, I don't know what I want to do. What's your message to somebody who might want to be explore the path of public health?
So depending on what level of education what institution and what level of education they are trying to achieve. So for those that are within the associate's and bachelor's degree area, there's a lot of opportunity for you to explore and take public health courses within your general requirements. And even if you already have a major, there may be opportunities at your school to cross-register and do some elective courses that are within the field of public health, like epidemiology or intro to biostatistics or intro public health or epidemiology. So I would explore what is your course curriculum at your institution and then kind of go from there. For our individuals in the master's, PhD, doctoral, medical, allied health services degrees in graduate school, I'd say they're a little bit limited in if they aren't already in a public health master's program or doctoral or PhD program. It might be difficult to do public health coursework, but the same rules will apply of them exploring their course catalog and seeing, is this even provided at my school? We had a huge influx since COVID-19 of public health programs, also online programs. So if you are considering going back to school and feel like you just would love to get some more education, there are more opportunities. And there's also opportunities for certified public health practitioners, the CPH, and then also the CHES, which is the Community Health Education Specialist certificate. And both of those can add to your knowledge within the public health field. But I think ultimately, public health really touches everything. It touches education, business, academics, medicine, science, education, you name it. Public health is in it. And there are so many ways that you can pivot your degree to focus on something related to public health. So I would say that it's not ever too late. I'm a lifetime learner, so I'm always trying to find ways to learn more or absorb more information and be on the cutting edge. And so with that in mind, I'm always trying to figure out, how can I connect the dots for something that might not have made sense 5, 10, 15 years ago that we're dealing with currently? And when you think about that prevention or that different mindset, it can really help to turn on that public health desire to learn more. But overall, I would say that I would explore your school's options. And even if you're not in an academic institution, there are several community-based organizations that are probably local to your area that are focusing on public health initiatives that you can get involved in. And I would also encourage people to volunteer. Volunteering is always a great way that you can not only give back to your community that you live in and that you're a part of, but also you can make connections and friends and lifelong partnerships with individuals who are trying to create change and promote health and wellness in your community. So I think if you go along those lines, you could be successful in joining the public health workforce. But just because you don't have public health in your job title doesn't mean that you're not impacting change for populations of persons. And I think that that's the most important part about all the work that we do.
Absolutely. Yesterday on CBS Morning, there was a story about some people in Texas. They had met on this program app called Nextdoor. And so the lady was retired, and somebody had said, she had treatment and she couldn't find how to get there, and she volunteered. So she volunteers and she's taking this person to all her doctor's appointment to get chemotherapy and the other one. And the other person also was legally blind and volunteered to drive that person to work. And so I was saying that this is social capital, which is for public health is a very big thing. And you think that you have to know somebody to build your social capital, but they found themselves on this app Nextdoor and they've connected. And because of that connection, which we know that people are increased risk for poor health outcome if they're socially isolated. And so that's why public health advocates for the building of social capital so that you can have people to talk to and things to do with yourself. Absolutely great phenomenon. I wanted to ask you about the Maryland Public Health Association. The Maryland Public Health Association is the state arm of the American Public Health Association, which, by the way, is really excited to be celebrating National Public Health Week this week, and
Yes.
the state of Maryland, and we like to bring our public health practitioners together. What sort of ideas, suggestions do you have that, what do you think are the benefits of having a professional body as the association, and how can we draw in professionals in the state who are not members of the association?
Mm-hmm. So, public health folks, we come from all different walks of life, all different age groups, all different backgrounds, ethnic backgrounds, race, genders, etc. And so I think the first rule of thumb would be to find some and figure out what is the audience. So are we trying to focus on recent graduates? Are you trying to focus on the senior professionals who are at the executive level? Or are you trying to do everything in between, from folks who are in high school all the way up to those who are retired and have all the subject matter expertise that they can share? So once you identify the audience of specific initiatives or the organization as a whole, then you can maybe have some different tracks to encourage individuals within those populations to apply and to join. And then when we're talking about events and programming, there might be a all over mixer so that everybody's mixing and mingling. But if you had something with all the schools that have public health programs as a mixer, or one program that has alums of these schools as a mixer, and then folks who are prospective students as a mixer. I think every population should have something for everybody that brings us all together, and webinars and other virtual events. But then things that are in person, I think because of COVID, so many people have hated being on Zoom after 2020 because you were just always on Zoom and there was no off button to it. And so now I think folks really want to get back in person, be engaged, do some networking, really touch shoulders with people to figure out what was your public health journey? How did you get here? Because it's not a linear path. All of us, we go all around, and there's so many different ways to get to public health and get to the places that we are. And so at each individual step within the public health career, I think those individuals would really benefit learning from each other in those smaller cohorts, but then maybe coming together for bigger cohorts, volunteer fairs or volunteer activities, social mixers, things like that. I think those all are things that get people outside of work and more into what are the social needs of our workforce, because folks are burnt out, folks are tired, folks are a lot of things. And so to remind ourselves, you're doing a good job, you're doing the best you can. And here's some other individuals that you might have never known are in your same state that are doing the exact same thing or doing something completely different at a different organization. We can really build that network and that workforce to not only know each other, but to support each other as well.
Absolutely. National Public Health Week, we have 3 core events that Maryland Public Health Association is doing. Today, they're having a gardening event at the library. Yeah, at the library downtown, because it's Healthy Neighborhoods today. The theme is Healthy Neighborhoods today. So, the library, just to draw people in from the community to attend who are not professionals. Tomorrow, it's having an event, a webinar online about climate change. And on Thursday, it's collaborating with the Montgomery County Fire Department to do about, safety in the house and all of that. So it's really a collective bringing. We have students chapter, we have an advocacy chapter that works with, passing legislation in the state, communications department, which is the committee that's producing this program, and really having different ways in which we bring the professionals and the young people coming so that we can mentor them and see, what's the pathway.
Exactly. That part right there, the mentorship, because I know for me personally, any opportunity that someone needs mentorship, I always am absolutely. I will find the time to do it because I know how many people that came before me that helped me along the way and made those connections. And it really is invaluable when you know certain people in certain circles to be able to put you in those same circles where you want to see yourself, or even just to make a connection of a warm handoff for a job, or maybe just to join an organization or an association or anything like that. It really is a great tool that we need to utilize more within the public health space. So that's phenomenal.
Awesome. Well, Dr. Marissa, it's been so wonderful talking to you. Before we round up, I wanted to give you the opportunity. Any last words, any last thoughts, any last ideas you want to share with our audience?
Thank you so much for the conversation. It was really great to hear more about MD, PHA, as well as getting to know you, Dr. Agbeyegbe, and have a really great discussion. But for those that are listening and watching, I'm always available to connect on LinkedIn, as well as via email at drmarissarob@gmail.com. And I'm looking forward to how these conversations really help to encourage folks to learn more about the field of public health and reach out to the professionals that are a part of this series, but also on LinkedIn, as well as through the MD PHA. So thank you so much for the opportunity and appreciate your time today.
Thank you. Well, viewers, this is the end of today's episode, Your Public Health Professional on You, a program of the Maryland Public Health Association. Questions for us? Comments for us? info@mdpha.org. We look forward to coming back to you with another episode shortly. Thank you and bye.